Dear colleagues, good morning or good afternoon, depending which part of the globe you are, or good evening. My name is Giacomo Bellani. I'm Associate Professor of Anesthesia at the University of Milan Bicocca in Monza, Italy. And I'm happy to share with you today some new results we obtained from the LungSafe database in regard to the association between respiratory mechanics and outcome. And I wish to thank the organization of this ISICEM for having me with you. These are my conflicts of interest, some ventilator companies, but nothing really related to this present talk. The main conflict, it's not a conflict, but the main disclosure I need to mention is that this is not Giacomo Bellani's work. It's a teamwork from a large group of people who did develop the LungSafe project. So John, Tai, Fabiana, and this analysis was run mainly by Emanuele Rezzoagli, who is one of our fellows here at the University of Milan. What I will be showing you, it's preliminary data, so please keep this in mind. The background and rationale of this analysis I will present you today is, I think, rather simple. I hope not simplistic, but simple and straightforward. We do know that several indexes have been proposed as, let's say, bedside markers of severity or risk factors for the development of VILI. We started from, like plateau pressure, and then we got into something more sophisticated like driving pressure, mechanical power, as we will see. Most of these indexes were evaluated independently in different cohort of patients, looking at different outcomes, benchmarked, if you wish, in against different parameters. However, we felt that establishing the prognostic value of different indexes would be important for several reasons. For example, this could be used to stratify the patient severity when they enter a clinical trial or an observational study, or even more importantly, if we decide to target one of these indexes with a given therapeutic strategy, such as extracorporeal CO2 removal, it is important which one it should be targeted. And in terms of the indexes I will focus on in my talk, of course, we are all aware of the driving pressure index. And from the very beginning, the driving pressure was validated, if you wish, showing that it has a strong association with the risk of dying. And so, as oftentimes occurs in ARDS, not having a benchmark for ventilator-induced lung injury, we do use mortality as a surrogate. And this is also something I will do today in my talk. And we also did a little bit of analysis of, let's say, of research in this field, and we highlighted a number of factors which are associated with the worst outcome in the LungSafe. The usual suspects such as age or immune suppression, hypoxemia, but what is important, also respiratory rate is associated with an increased risk of death in ARDS patients. And so this is sometimes pointed out as a weakness of the driving pressure because it does not take into account the respiratory rate. Recently, I would say more recently than with driving pressure, more, I would say, complex and sophisticated concept has been introduced, which is the mechanical power, introduced by Gattinoni, which basically calculates the elastical power, the mechanical power related to mechanical ventilation, as if the lung, the respiratory system, let's say, would respond to this power like a classical physical machine. And essentially, the power has different components, but I would point out that the major differences, as looking just at driving pressure alone, is the fact that respiratory rate is taken into account, but also the role of PEEP. And recently, some investigators looked at the association between mechanical power and mortality and found some degree of association, but I would say not as compelling as for driving pressure. Particularly, they found this paper by Ari Serpaneto found a, let's say, step step-shaped increase in the risk of death when mechanical power exceeded the given threshold of about 18, 19 joules per minute. So really you have two areas with a, let's say, lower risk of death, higher risk of death, separated at a given threshold. Then other investigators found an association between the mortality rate and mechanical power normalized to predicted body weight, but this starts to be a little bit too many normalizations in my personal view. So we ran an analysis. I'm sorry this looks very small, but I just want you to focus on this cell here. We ran a secondary analysis, or I should say Emanuele ran a secondary analysis on the LungSafe database, looking at all patients with ARDS, aligning them on day one, taking patients only on controlled ventilation, on fully controlled ventilation, so that the set respiratory rate was equal to the measured respiratory rate. And patients in whom the entire data set could be calculated. So unfortunately, many patients had to be dropped because plateau pressure was not available. So which index did we evaluate? A number of those. For the sake of time today, I would focus only on those that are really, I would say, bound to mechanics, while we also looked at other indexes that include the gas exchange function of the lungs. Today, I will present you the, let's say, prognostic value of driving pressure, mechanical power times respiratory rate, driving pressure times respiratory rate, or driving pressure squared times respiratory rate, so that driving pressure and respiratory rate do not weight in the same way, but driving pressure weights more than respiratory rate. It's a little bit simplistic, maybe a little bit naive, but it's an approach. First, again, this is a little bit busy, how these different parameters trends with the severity of the disease. And for all the parameters, we found an association between increasing severity of the disease and increasing value of the parameter. So, for example, driving pressure has a clear trend over mild, moderate, and severe ARDS, like also mechanical power does. However, when we looked at the association with mortality, we found that some variables at univariate level were tightly associated with outcome, like driving pressure or driving pressure times respiratory rate, whereas, for example, mechanical power at univariate analysis was not. Then we divided the variables into quintiles and looked again at the trend, at the association between these trends, these variables, and the outcome. It's quite interesting to see that there is an association for driving pressure and square power of driving pressure times respiratory rate quite tight with outcome. And mechanical power does show some association with outcome, but again, we sort of have a threshold effect, and the value that we found is not exactly the same, but quite similar to what was found by Ariser Paneto, suggesting that a mechanical power above 19-20 joules per minute leads to an increase in mortality, and the signal is rather flat above and below. Of course, this mortality accounts, ARDS, sorry, and mechanical ventilation accounts only for part of the mortality which we see in our patients. And so we also expressed adjusted, let's say, the risk of death for other factors like non-pulmonary SOFA score, and age and so forth. And again, we found a very remarkable association between driving pressure squared times respiratory rate and the risk of death. Finally, to explain a little bit the let's say the lack of association between mechanical power and mortality, we looked a little bit deeper at the role of PEEP, and we have seen that PEEP has really a U-shaped association with the mortality. There is a decreasing mortality for increasing levels of PEEP, but then these jump up again for higher levels of PEEP. So probably this nonlinear association between PEEP and mortality explains why mechanical power does not have a very tight association with outcome. And finally, again, the area under the curve to predict mortality is rather low, but the highest one was found for driving pressure squared times respiratory rate. So I go to my conclusions, which, as the data and the results are preliminary at the same way are the conclusions, driving pressure and also driving pressure square respiratory rate are strong predictors of 90-day mortality in ICU, whereas mechanical power was not associated with ICU mortality. And if our benchmark is mortality, then the best predictor of it is driving pressure square times respiratory rate, although the AUC is still rather low. And with this, I thank you very much for your attention.